right. Okay, so we will start with our disclosures. Accreditation and EOE statement from UAB. Dr. Betensky will go over her disclosures. And then for attendance, you can scan the QR code or you can click on the link that's here. It's not going to expire at midnight. It'll be open for a while.
All right, well, thank you all for joining. So we have two presentations. So we'll first start with a case and then we'll go into our didactic session for today. Dr. Canner apologizes. She just has another meeting today, so she cannot join the call. But we're excited to hear from Dr. Patel. So she is initially from LA, spent some time out there, but is currently doing a 4th year at St. Jude, specifically in sickle cell. So anybody who has any contacts or any job openings, please let her know so that way she can have a job when she graduates her fellowship in June. So you want to share your screen?
Yes, great, thank you. All right, can everyone see my screen?
Yep.
Perfect. All right, so my name's Amie again. And so this case that I want to present is an inpatient case that we saw in the prior week. And so he is a 17-year-old male with hemoglobin SS disease. So he was admitted the second time on October 16th of this year. And so he was admitted for a vaso-occlusive crisis. He had a prior admission the week before, and he typically is a frequent flyer. So he has frequent vaso-occlusive crisis, about 7 in the past 12 months. And so his past medical history, like I said, he has frequent hospitalizations for VOCs. He has bilateral hip AVN. He status post a right total hip arthroplasty in June of 2020 and a left total hip arthroplasty in December of 2021. He has chronic pain in both of his hips from his AVN. He had a cholecystectomy in November of 2021. And he also has a history of obstructive sleep apnea. He status post an adenectomy as well as a tonsillectomy, both in 2010. In general, he does not get transfusions frequently. He mostly just has gotten transfusions in his life prior to his surgeries. So his psychiatric conditions include anxiety as well as ADHD. His mom has a history of anxiety and depression. In general, he feels as if he has to be strong for her and feels like a burden on the family. He has difficulties opening up to others, and he has been having difficulties with coping with his pain, especially now that he's been having increasing pain frequency. While he's been hospitalized, he basically just sits in the dark. He has no activities. He doesn't even watch television. And this behavior is kind of a new phenomenon in this past year. His friends are not aware of his sickle cell disease. His mother is his main area of support, and he follows with psychology pretty regularly. In terms of his social history, so he's currently in the 12th grade. He recently just started a job in retail, and he lives in Memphis with his mother as well as his younger half-brother, who's 13 years old. In terms of medications, he's on hydroxyurea. He started that in February of 2009. He was at the age of 4 at that time. He is currently on 2,200 milligrams, so that's 30 mg per kg for him. And his adherence has especially worsened in the past year. He's also was initiated on crizanlizumab due to the increasing pain frequency he was experiencing. So he was started on that in June of 2022. And so he's been on meloxicam daily for his avascular necrosis, and he's being followed with pain team as an outpatient. He's also taking a vitamin D supplement. In terms of his allergies, so in October 15th of 2019, in one of his hospitalizations, he was given IV lidocaine, and he was noted to have confusion. And so he was also on opiates at that time. And so they thought maybe this was related to the lidocaine. They ended up stopping the lidocaine, and they listed it as an allergy. He was again then retrialed on lidocaine in May of 2021, and he was placed on a 4-hour infusion, which he was able to tolerate. He then was trialed again in June of 2022 on an 8-hour infusion and tolerated that as well. During this past admission in October, he was trialed on lidocaine and he tolerated it, and it was removed as an allergy. And then another allergy is ketamine. So in February of 2021, he experienced hallucinations while on 0.25 mg per kg per hour. He has used ketamine previously for 3 admissions prior to that one in February 2021. His dose during those admissions had ranged anywhere from 0.1 mg per kg per hour to 0.25 mg per kg per hour. And typically when he had used ketamine in the past, there had been a significant reduction in his pain scores, and as well as his PCA was typically discontinued 24 to 72 hours after initiating the ketamine. And so explaining to you a little bit more about his prior hospitalization. And so he was hospitalized earlier on in this month from October 9th to October 14th. And so he was admitted for a total of 6 days. He was admitted for a vaso-occlusive crisis in his glutes, which could be related to AVN. And he was also having facial and molar pain. His pain score on admission was a 7 out of 10 in severity. He did not require any transfusions during his hospitalization. When he was admitted, he was started on a dilaudid PCA of 0.25 basal, 0.25 of bolus, both clinician bolus as well as patient bolus. He received a massage with their integrated medicine on October 10th. And then he also received an 8-hour lidocaine infusion daily for 4 days from October 10th to October 13th. We also consulted oral and maxillofacial surgeons for his molar pain, and they noted on x-ray that he had a 3rd molar that was impacted, and they had recommended removal as soon as possible. They wanted dentistry to evaluate for the need of other interventions prior to removal, so it was not removed while he was an inpatient. His vitals signs had normalized, and he stated his pain score at discharge was a 3 out of 10 in severity. He wanted to go home as he had plans the next day. He was discharged with morphine, extended release 20 milligram BID taper for 4 days, as well as PRN/PO dilaudid for breakthrough pain. He then presented again 2 days later and it was admitted on 10/16. He was having a vaso-occlusive crisis in his neck, upper back, and shoulders. His pain never quite had resolved from his prior admission. His pain score now on admission was an 8. In terms of his vital signs, he was tachycardic, he had elevated blood pressure, but otherwise his other vital signs were normal. His CBC, so his white count was a little elevated at 21.63, his hemoglobin was 9.4, his hematocrit was 26.6, and his platelets were 593. That hemoglobin was at his baseline. His reticulocyte count was 14.7%, with his absolute reticulocyte count being 397, and his ANC was 15,208. His CMP was completely normal, except he did have an elevated total bilirubin of 2.1, which again was at his baseline. His 2-view chest x-ray was within normal limits. In terms of his pain regimen, he was started on a dilaudid PCA pump of 0.26 basal and then 0.26 of clinician bolus as well as patient bolus. And that was right when he was admitted. We consulted the pain team and they decided again to trial an 8-hour lidocaine. And he also received a massage on 10/17, so the day after he was admitted. His pain score was consistently a 7 to 8 out of 10 in severity from when he was admitted all the way up until he was given low-dose ketamine of 0.1 mg per kg per hour on 10/18 in the afternoon. His pain score then started to decrease the next day on 10/19, and it started going down, and so his pain score was 5 to 6. We were able to decrease his dilaudid PCA to 0.1 mgs or across the board basal and bolus. And then on 10/20, his pain score decreased even further to a 4. we were able to switch over to morphine extended release 30 milligrams BID with a dilaudid PCA boost of 0.1. And then he was discharged on 10/21 with a pain score of 0. Unfortunately, the documentation of the dilaudid PCA of how much opiate he actually got was incorrect for the second admission. So I can't compare the total amount of opiates he received from his first hospitalization to a second hospitalization. However, his total length of stay was 5 days in his second hospitalization, which was 1 day less than the prior hospitalization. He also did have a complete pain reduction compared to the prior admission. And so this is a schematic here, and it shows the role. Oh, sorry. Gonna have to go through this again. I apologize. So this is schematic here. And so it shows the role of opiates in the development of central sensitization. And so continuous and spontaneous firing of sensory nerves leads the generation of acute pain into chronic pain. And so as you can see over here at the input, and then the rostral ventromedial medulla forms part of the descending pathway that modulates nociceptive neurotransmission at the level of the spinal cord dorsal horn. And so the involvement of the descending RVN system from opioid activation has been shown to lead to opioid hyperanalgesia. And so the chronic administration of opioids increases level of pro-inflammatory cytokines, all which lead to hyperanalgesia and increased pain. So just in summary and in conclusion, chronic opioid use increases the role in peripheral and central sensitization, which causes increased severity and the duration of pain. And so despite all of this, opioids so far have been the mainstay for treatment of acute pain related to sickle cell. And so this slide was taken from the ASH clinical practice guidelines. And so some patients don't respond to opioid therapy alone, which is why the ASH panel recommends a multimodal approach to analgesia. And so pathways to reduce the opioid burden would provide non-opioid analgesics to treat acute pain, with a goal of reducing the total dose and duration of exposure while maintaining or improving analgesia. And so the ASH guidelines now recommends the use of ketamine as a non-opioid pharmacological intervention for acute pain refractory to opioids. And so they suggest ketamine as an adjunctive treatment for pain that is refractory or not effectively treated with opiates alone. This recommendation assumes safe administration of ketamine infusions in the hospital inpatient unit at centers that have expertise. And so they recommend administering doses starting at 0.1 to 0.3 mg per kg per hour with a maximum of 1 mg per kg per hour. And so the determination of what is considered refractory pain is still up to the clinician's discretion, and there isn't further clear guidelines based on when it should best be used. And so in terms of other potential medications to help relieve refractory pain to opioids, so lidocaine has been studied. And so this is a retrospective study published in Blood. It was done at St. Louis Children's, and it sought to implement an IV lidocaine guideline for children and adolescents with sickle cell vaso-occlusive pain. And so they evaluated patients with vaso-occlusive pain during 2018 to 2020. They identified 61 unique different patients with 174 IV lidocaine administrations during 164 hospitalizations. And they evaluated lidocaine levels and also their side effects. And so in their cohort, they found that lidocaine was safe, it was tolerable, and it did improve pain control. They did find mild side effects in about 3 patients, but they were able to initiate IV lidocaine from 1 to 1.5 mg per kg for 48 hours, and they typically initiated it within 24 hours of admission for severe pain. There was another study done at the University of Chicago. They conducted a retrospective analysis to determine clinical outcomes in hospitalized adult patients who use ketamine as well as lidocaine infusions as an adjunctive pain management therapy. And so they reviewed a cohort of 330 adult hospitalizations. And that was 68 unique different patients. And so they evaluated those hospitalizations from July 2017 to August 2018. And they said that compared to patients that did not receive infusion therapy, ketamine and lidocaine accounted for a retrospective relative decrease of 28% and 23%, respectively. And so an average of daily morphine consumption. So ketamine decreased to 28% and lidocaine 23%. Both ketamine and lidocaine infusion therapies were thought to be effective in reducing opioid consumption for patients with vaso-occlusive crisis. The studies that have been done in sickle cell disease, though, that utilize lidocaine, they did not mention if any of these patients had a component of neuropathic pain. And so lidocaine for neuropathic pain has been studied in individuals who do not have sickle cell disease. And so this study was done in Seoul in South Korea that used lidocaine infusion treatment for neuropathic pain. It was a randomized, double-blinded and placebo control. They enrolled 42 different patients, and they compared the efficacy of lidocaine infusions of 3 mg per kg versus placebo of normal saline that they gave once a week for 4 consecutive weeks. And they evaluated patients who had post-herpetic neuralgia or chronic regional pain syndrome. And so they found that lidocaine infusion therapy, it did provide a short-term pain relief compared to the placebo. And so when evaluating our patient, lidocaine had not decreased his pain score as significantly as ketamine has in this admission as well as in prior admissions. And so in all of our patients here at St. Jude in the clinic, we do something called the pain detect score, and it could suggest if they have a component of neuropathic pain. So his score was a 7. And so that suggests that he unlikely has a component of neuropathic pain. His scores of 13 to 18 suggest possible neuropathic pain, and scores greater than 19 out of 38 represent a 90% likelihood of neuropathic pain. So this pain detect questionnaire, it was initially developed to detect neuropathic pain components in adult patients with low back pain, and they recommended it for use by non-specialists. But again, this tool has not necessarily been validated in sickle cell disease, but it could be something that could be used to screen for neuropathic pain. It's difficult to say if our specific patient did not respond to lidocaine as well because he didn't have a component of neuropathic pain, and that's why ketamine worked a little bit better for him. But this is all something that needs to be researched and evaluated further to figure out when it's best to use what non-opioid adjunct therapy to help decrease opioid consumption. And so I just kind of wanted to bring it up to the larger group for what your thoughts are and experiences with using ketamine and or lidocaine at your institution. And then also some other things that I wanted to have people is just how any success stories of how it was implemented at your institution, and then who's prescribing it, you, or is it restricted to pain service?
Fantastic job. So we can open that up. So I'll start with at least Children's of Alabama side. I don't know if anybody from the UAB adult side would be able to answer that. So we just actually presented being able to use ketamine as pediatric hemonc on the floor. So similar, so PCAs are managed by anesthesia, except for certain situations. And so it's sort of joint between palliative care and hemonc would be, can we also add ketamine? And so we sent that as ASH guidelines over, and so we're waiting to get word. So we have not done it yet. But yeah, we agree that, some non-opioid interventions are appropriate. And then after people give that, I also want to ask you about some of your other non-opioid options, but anybody else have any experience with ketamine and lidocaine at their hospitals?
We use ketamine in our hospital. So for every patient with sickle cell disease that gets admitted, they get a pain consult automatically. So the pain team helps managing all the PCAs. We're able to order them, but in theory, we should, consult them. And when we're making changes, we should talk to them about it. We feel obviously more comfortable making changes on the dilaudid or morphine on the opioid PCA than on a ketamine PCA. We haven't had any issues. Pretty safe, works great for our patients.
Anybody on the adult side able to use ketamine or lidocaine?
Hi, Dr. Ogle from Memphis. We've used ketamine over here, and from the patient standpoint, I feel like they either love it or hate it. Either it makes them hallucinate and they don't ever want to get it again, or it actually helps them.
I would say from the pulmonary point of view, ketamine will be much more preferred over opioids. If the patients especially have asthma or acute chest syndrome, because we use it for patients with asthma exacerbations during bronchoscopy because it's bronchodilator. So it may help patients who have oxygen issues or breathing issues with pain. It will be a better option. We know that opioids can induce hyperventilation and increase the risk of developing acute chest syndrome for patients who are admitted with pain. But we need to wait for the data for the ketamine, if it can reduce the possibility of hyperventilation and progression to acute chest syndrome. But it is a better option for us that we use it for sometimes for our patients that are not sickle.
Sorry, there's a question, please. Toby from Mississippi. Do you keep them on the tele when they're on the infusion because of the risk of arrhythmias? Just curious.
They kept them here on the monitor.
Hi, Amie, this is Raina from Methodist. I wanted to let you know that when we have patients admitted with a lot of refractory pain, we have to use our pain service, but they are able to use the ketamine with the direction of the anesthesiologist, and it's proven to be very beneficial for our patients that are in a lot of refractory pain. So we're not able to prescribe it, but with the pain service, it is a service that's offered for them.
Thanks. Yeah, it seems like at most institutions, it's limited to pain service and anesthesia, mostly because we had never really been taught on how to manage ketamine.
And then in the last 5 minutes, can you also talk about some of the stressors and sort of the other non-opioid interventions? I mean, have you guys been trying antidepressant? I mean, what have you gone through from a psych standpoint to try to improve that component of the pain, especially with the low concern for neuropathic based on your score?
Mm-hmm. And so he definitely does have more of a psychosocial, especially in this past year with increased frequency of admissions, and just in general, it seems like his depression has worsened. Parents at this point are hesitant to start any sort of antidepressant. He's been following with psychology regularly, almost weekly at this point. And so that's one of the big interventions that we're doing, is more just a therapy. But I think it's a discussion that we need to have again with seeing psychiatry and possibly starting on antidepressant at this point. In terms of, he also, while he's inpatient, sees integrated medicine and responds pretty well to their adjunct therapies. And so he got a massage a few times while he's been here inpatient. Also acupuncture is something that they're able to do while they're inpatient as well as outpatient. And so I'm going to try to have him reestablished in the integrated medicine clinics while he's as an outpatient as well.
Yeah, no, it's really impressive that they get massage. It seems like just hands-on could, be some benefit to that patient. But yeah, that'd just be the concern with all the, whether it was the surgeries that were the triggers for this, sort of progression or other stressors in his life. But yeah, if it's not neuropathic pain, just worry that this is, something that, again, we know that depression and psychological issues are just underdiagnosed in our patients. So.
Yeah, and that's definitely a conversation I need to revisit and have with him and his family.
And when you guys do start, what do you normally start with? I mean, is it duloxetine?
Depending on what it is. So if I think it's more a component of like neuropathic pain, probably with the chronic pain, then probably duloxetine. But for him, if I'm mostly thinking depression, then potentially just starting him on Zoloft.
Okay.
So an SSRI, but it's kind of hard to say because this pain detect score isn't necessarily validated in sickle cell disease, and it's validated for very specific reason. And so it's difficult to extrapolate completely.
Yeah, and it was interesting that, because I was going to assume that you had the patient on Neurontin just from at least the past history of Doralina's interest in Neurontin and sickle cell, but so this patient has not had Neurontin?
No.
Okay.
I think previously, yes, but it's not taking it now. And I have to look back at the notes to see how they responded.
Okay. Any other questions or comments?
My question, I don't know if I don't know if you heard me the last, I was curious, in places where they don't have a pain management hospital service, when you start lidocaine infusions particularly, what's the protocol? Do you put them on the tele? Do you restrict it to non-cardiac patients? That's my concern with lidocaine infusion.
And that's a great question. And that one study that did it at St. Louis Children's, so they were saying that it's safe and efficacious. They put them on tele and monitored pretty closely, and they did it at lower doses. But again, I don't know if I would feel comfortable ordering lidocaine without pain service managing it. It might be something where you have to trial one time in one patient, but it definitely, they required monitoring.
Okay.
Hi, sorry, this is Power. I'm in clinic, so it's a little difficult for me to join in. So yeah, so Amie's absolutely correct. We usually do that. And if a patient has a history of any cardiac history and with abnormal EKG or echo findings, we usually do not put them on lidocaine infusions. So we make sure that the pain team knows about the cardiac history.
Thank you.
All right. Well, it's 4:30, so thank you so much for that. It was a great case and great job. And based on that, everybody look out for hiring opportunities. And we'll switch over. So Dr. Betensky is going to be talking about another issue that happens not as frequently as chronic pain, but we definitely see and have increased concern for venous thromboembolism. So Dr. Betensky is a fantastic young investigator who I met at the ASH Clinical Research Training Institute. During that time, I believe she was still in Philadelphia and has since taken a faculty position in St. Pete under the great mentorship of Neil Goldenberg, who also mentors one of our thrombosis people here, Dr. Hope Wilson. And so Dr. Betensky is developing some national prominence as a leader in sickle cell disease and thrombosis. And so we look forward to her didactic session of this talk today. So thank you for presenting.
Thank you so much for the presentation. Can you see the right screen? Like yeah, okay. So yeah, a little bit of a change of topic. What I do is clots. What I talk about is clots. So today I'm going to present a little study that we did looking at the frequency of recurrent thrombosis in children with sickle cell disease using the TriNetX Research Network database. And these are my disclosures. So just very briefly, as you know, sickle cell disease is characterized by a wide spectrum of clinical complications that result in irreversible organ damage and early death. And one of the hallmarks of this disease, as we probably all of us know, is that there's damage to the endothelial wall. There's the development of vascular endothelial dysfunction that, among other things, it predisposes patients to having a chronic prothrombotic state that increases the risk of VTE, venous thromboembolism. And retrospective studies have shown that the rates of first-time VTE in children with sickle cell disease are significantly higher than the ones seen in the hospitalized general pediatric population, about 1.7 to 2% versus what's quoted of 0.2 to 0.6 in non-sickle cell disease children or children with sickle cell disease. And these rates are similar, maybe a little bit lower than what you see in children with malignancies, but certainly similar to what we see in children with congenital heart disease. So definitely a significant rate of thrombosis. However, despite knowing that this disease is associated with a prothrombotic state and knowing that there's an increased risk of VTE, we really don't know a lot about the key outcomes of VTE, particularly which patients are going to develop recurrent VTE. We also don't know what are the risk factors and prognostic factors associated with the development of complications following a VTE, such as recurrent VTE. And this knowledge gap really prevents us from developing disease-specific guidelines addressing both treatment of VTE as well as secondary prophylaxis in these patients. And we suspect that not knowing what to do with our patients when they develop a clot really causes or leads to significant variability in the management of VTE in pediatric sickle cell disease. And we actually, last year, we performed a cross-sectional survey of pediatric thrombosis hematologists that were members of 3 international subspecialty societies. And we basically asked them, what has been your experience with sickle cell disease and VTE in pediatric patients, and what are your management approaches? And what we noticed is that in terms of the significant variability in terms of the use of anticoagulation therapy, so as you can see, nearly half of the physicians will not prescribe anticoagulation therapy for asymptomatic DVT, the venous thrombosis. However, the majority of them will do it for asymptomatic PE. Similarly, when you look at the use of prophylaxis, nearly 20% of physicians will not prescribe prophylaxis in children greater than 18 years old who are critically ill in an ICU and who have sickle cell disease. And if you think about it, in an adult hospital, most of these patients will immediately get some prophylaxis for hospital-acquired VTE, even when admitted to a regular floor. And finally, where we saw the most variability was actually in the duration of anticoagulation therapy. We could all agree that for provoked VTE, the majority of those will treat patients from 6 weeks to 3 months, but things get a little bit more crazy when you look at provoked PE, where nearly 40% of physicians who answered this survey will treat for longer duration of therapy. And then for unprovoked VTE, it was a little bit more all over the place. Some people will treat for shorter duration, other people will treat for longer duration. And another findings, you know, there was a lot of difference in what people will perceive as risk for VTE in patients with sickle cell disease. And it was interesting to see that, you know, when patients get admitted for sickle cell disease-related complications, such as acute chest, that's not perceived as a high risk for VTE, unlike other things like oral contraceptive pills. And finally, half of our physicians indicated that they were somewhat to not at all confident in making decisions regarding the duration and intensity of prophylaxis in this patient population. And they had a lower than expected perceived risk of recurrent VTE in the pediatric sickle cell disease population, meaning they don't think patients are at high risk of VTE. And so the reason why it is important to understand the outcomes of VTE is because that's, you know, when you think about why you give anticoagulation therapy to your patients, is really thinking about decreasing the risk, not only of extension embolization of an acute event, but also decreasing your risk of VTE recurrence. So in order to understand the intensity and duration of therapy that your patients should receive, you kind of need to understand what's really the risk of having VTE recurrence or any other complication associated with an acute VTE event. So in order to do that, what we decided was we wanted to investigate the frequency of recurrent VTE in children less than 21 years of age who had sickle cell disease of any genotype and a history of prior VTE. And we also wanted to identify prognostic factors, clinical-based prognostic factors associated with the development of recurrent VTE in this population. And in order to do that, we did an analysis of patient-level data from the TriNetX Research Network database. I don't know if you're familiar with it, but it's a global federated network of electronic medical records. At the time that we did this analysis, it included 42 healthcare organizations in the United States. And an inclusion criteria was basically children less than 21 years of age at the last encounter with a diagnosis of sickle cell disease of any genotype who had a history of a first-time or index VTE. And I'm not going to go through all the definitions, except I do want to highlight that, these federated databases are, they're not great for identifying cases of VTE, particularly of recurrent VTE. They have a poor sensitivity or poor specificity for that. However, we really were very conservative in our definition of recurrent VTE. And one of the key things is that we only consider recurrent VTE when the development of the VTE, of the recurrent VTE, was in a different anatomic location from the index VTE. So that way we knew it was a recurrent new event and not just the same index VTE diagnosis that was carried over all the admissions. So, the analysis was basically descriptive statistics, and we look at the 1 and 5 year recurrent VTE rates, and we did logistic regression analysis to investigate the association between putative prognostic factors and the development of recurrent VTE. So we included a total of 119 patients. The majority of them were female, or a slight majority. As expected, most of them were African American. Interestingly, a big proportion, almost half of them, had a pulmonary embolism, which is not the typical site where you see VTE in children who do not have sickle cell disease. Usually it's more frequent in the extremities. And also very interesting is that the presence of a central venous catheter was low in this cohort of VTE patients, which again, this is one of the main risk factors of VTE for children. So goes to show that patients with sickle cell disease really have this underlying prothrombotic state, and maybe the risk factors for thrombosis in this population are different from what we see in the general pediatric population. So when we look at the cumulative incidence of recurrent VTE, we found that at 1 year, the incidence of recurrent VTE was 8.4%, and at 5 years was 21%. This is really high. What's been published and what we can see from epidemiological studies in the general pediatric population is 3% at 1 year. So definitely we were very surprised to look to see these numbers. When we compare patient characteristics between the group that didn't have a recurrent VTE and the group that had recurrent VTE, there was nothing significant, statistically significant. However, there was a greater proportion of females in the recurrent. They were slightly older, and there was a higher proportion of upper extremity DVT when we compare the two groups. And then when we look at the candidate prognostic factors for recurrence in this population, we identify an upper extremity DVT, as well as the diagnosis of acute chest syndrome or pneumonia as candidate prognostic factors for the development of recurrent VTE in these patients. So obviously there are significant limitations with the study, most importantly that it relies, as I mentioned, on an administrative database that needs ICD-10 codes, who can be kind of not great for the identification of recurrent VTE. We try to mitigate these limitations by using hospital emergency department encounter codes only instead of just clinic codes. And we really were very conservative on our definition of recurrent VTE. We also were unable, there were other potential relevant risk factors like sickle cell disease genotype, duration of anticoagulation therapy, use of disease-modifying drugs that are really important. However, we were unable to identify those because of limitations with the type of database that we were using. And obviously, we weren't able to determine a temporal relationship between some of the risk factors and the development of recurrent VTE. Nevertheless, I think this is really one of the first studies that shows that these patients have a high rate of recurrent VTE. 21% at 5 years is definitely high. We potentially identify some prognostic factors for the development of this complication, including a DVT in an upper extremity or a diagnosis of acute chest pneumonia. And overall, this study highlights really we need prospective, comparative, multi-center studies to reliably, validate this data, establish rates of recurrent VTE, and really identify the prognostic factors for this complication in patients with sickle cell disease to allow us to develop disease-specific guidelines for the management and prevention of this complication. So that's all I have. Any questions?
Excellent job. So we'll open up to questions. I'll just start with, in terms of, in terms of your, the use of ports, especially in our chronic transfusion patient, in terms of the pathophysiology, how do you sort of think about patients who have lower S levels, but with, lines in place? Is there any protective effect you think of transfusion on, this increased risk that sickle cell patients have, or is it just simply, ports plus sickle cell, can increase that risk?
Actually, we think, and it's interesting that you bring that question because I'm in the process of resubmitting my K award, and we're looking at trying a prospective multi-center cohort to validate this data. And one of the risk factors that we're including for the development of VTE is RBC transfusions. And I don't know if you know Cassandra Josephson. She's now our director of our institute, and she's one of the mentors. And she has found an increased risk of VTE in patients that are transfused, not sickle cell disease patients, but in other patients without sickle cell disease that receive transfusions. And it will be interesting to see if that is the same in the sickle cell population. So as you say, you're decreasing, the amount of S percentage, and in theory, the amount of hemolysis, release of free heme, damage of endothelial damage, etc. But is that enough to really decrease this prothrombotic state and to really decrease the pro-inflammatory state that we think is that interplay that causes the development of VTE? So to answer your question, I'm not sure, but
you'll get your
if I get funding, I get funding, I may be able to answer.
Amar?
Hi, Marisol. I'm a pediatric pulmonologist, so I may be kind of a stranger for this group, but I'm interested in your idea about why they have more thrombosis in the lungs than in the extremities. Although we know that there is more stagnation in the extremities than circulation in the lung. I have ideas, but I just wanted to hear from you, what was your explanation? And this will be followed by another question.
I think it just relates to the physiopathology of VTE development in these patients. Unlike, an otherwise healthy child where there's no endothelial damage, there's no vascular disease, you will find that the most common trigger for a VTE event is going to be a central venous catheter, which usually goes in an extremity. So usually you will see clots associated to that. Even in NICU patients, when you think about the type of clots they develop, they're usually associated to the UAC. It's always a central line. So it's just a different. I think the driver in there is the endothelial damage caused by a foreign device. In the sickle cell disease population, though, we know there is this chronic, ongoing, nonstop endothelial damage. So I think, it's sort of like a free-for-all. Clots can develop anywhere. And I think that, I really think that a lot of these clots are in situ, develop in the lungs. These are not the PEs that we see with other patients, right? These are clots that develop right in the vasculature of the lungs, related to potential episodes of vaso-occlusive crisis, acute chest, with the background of the underlying vascular endothelial damage. I don't know.
Yes, and I agree with that, because when we talk about PE, it happens in the pulmonary artery, not in the pulmonary vein, right?
Yeah.
which has probably the least saturated blood in the body, because by the time it reaches the lung, the oxygen content will be the lowest. That's why the sickling and the hemolysis will be at its highest in this circulation, in addition to passing into the pulmonary capillaries, which are very small compared to the veins in the periphery. So I think those two factors will predispose sickle patients to have more thromboembolic events in the lungs rather than in the peripheries, which is usually more common in the general population or patients with other underlying diseases. And this leads me to the questions. So you mentioned that acute chest pneumonia is a risk factor for recurrence of PE, which is a kind of VTE, which makes sense because those patients will have damaged lungs, will have more hypoxia, so they are more prone to endothelial injury, which will predispose them to recurrence. So have you looked at any association with diagnosis of asthma or obstructive lung disease? And if this is a risk factor for the first episode or the recurrence of VTE, because that will support another kind of theory that I'm working on mice, in fact.
We have not, but that's an excellent suggestion and something relatively easy to accomplish, especially with this type of data that we have, where we have all the diagnosis of these patients. So
exactly, you can just look at the ICD-10 code of asthma and correlate it with the first event versus no events and with recurrent events versus no recurrence. And I have a feeling that you'll see much more events in patients with asthma or obstructive lung disease and more recurrence, but of course we need to wait for the data.
That's a great suggestion. Thank you.
Are your mice getting clots, Amar?
Yes, they do. When I induce acute chest syndrome and we look at the lung sections, they have a lot of pulmonary thromboembolic kind of events compared to sickle at baseline without acute chest syndrome, and of course compared to controlled kind of mice. So sickle mice, even without inducing acute chest syndrome, they have more thromboembolic events in the lungs than control mice. And then after inducing acute chest syndrome, they'll have even worse kind of thrombosis score in their lungs. So I think there is, as I said, when we induce airway obstruction in the mice, we see more kind of mortality, lower oxygen. We haven't looked at thromboembolic events in those with and without asthma in the mice, but this would be done much easier on the clinical side.
And from a timing standpoint, Marisol, do you think this is, they come in, they have a history of acute chest, they come back in with this event, they get another line placed, they may get freeze. Do you think it's the acute chest syndrome is the, causing the pathophysiology of the second clot, or do you think it's procedures that are doing that?
I think it's the sickle cell disease related event. I think it's the acute chest syndrome. I think it's the vaso-occlusive crisis. I think it's the ongoing or worsening hemolysis associated with those events, the increased inflammation or the increased inflammatory response. I think that's really what, of course, if you have a central line, well, you're just stacking risk over risk over risk. But as you can see, more than half of our patients didn't even have a central line in place during the period of follow-up and, still develop a VTE, which shows that, the way we think about central lines with these patients should be a little bit different. And it is important because when you think about otherwise healthy children who develop a central line associated DVT, which is what you most commonly will see in pediatrics, you pull out the line, most of the time risk factor is gone, right? That was the main risk factor. So you just treat for 6 weeks and you're done. But that's not the case with patients with sickle cell disease. And I think that is why it's really important to truly identify their outcomes, establish their outcomes and identify the risk factors in order to be able to determine the intensity and duration of therapy for these patients.
Other questions?
Yeah, one other thing that it will be hard to collect, but is the baseline oxygen saturation for patients at risk of VTE. Because I mean, it makes sense physiologically that those with the lower baseline oxygen saturation, they'll be more prone to have thromboembolic events.
How would you define baseline oxygen? Like at the time of a clinic visit or?
Yes, this is the $1 million question, and there is
Yeah.
no agreement about how to define it. But for us, for our population, the best way to define it is when we do sleep study on those patients, we usually record their oxygen saturation the first part of the night before they go into sleep. But the more accurate oxygen saturation is during sleep. So usually we use mean oxygen saturation during sleep, or the time spent below 90% during sleep. This is the most accurate, but of course, you only have few patients who will have sleep study
Yeah.
in sickle cell. So the problem with the oxygen saturation during the clinic, it's very diverse, because it all depends on how the patient was doing that day, how you measure the oxygen saturation, if they were like walking for long distance and they measure the saturation right away versus they were sitting like for half an hour before you measure saturation. All of those things can affect the oxygen saturation measurement. While in the sleep study, it's all under control. They arrive at the same time, they sleep study at the same time, and they measure the saturation with the same machines, with a standardized protocol. So that would be the best. That's why I'm saying it's hard to answer this question, but this would be very interesting. It's just, there is a big move now to look at how you measure oxygen saturation for patients with sickle cell disease, because the pulse oximeters that we use, they're not designed for first patient with sickle cell disease, and they're also not designed for people with dark skin. And we know that patients with African American descent, the pulse oximeter will overestimate their oxygen saturation by about like two points, which is a lot. So if the saturation is like 91% that you measure, it's probably around like 89, 88%, the actual oxygen saturation. So this can be a risk factor for thromboembolism and for recurrence.
Yeah.
And then always, the fun discussion of adherence to antithrombotic therapies. Any data on, how well they do, once you put them, if you want to put them on prophylaxis?
Unfortunately not, because again, for this particular database,
Right.
the data on drugs is not that good. So they are fixing that problem, but to the point that they actually do not encourage you to use the data at this point.
Okay.
Yeah, that is.
And anything in your own practice that you've seen, how your anti-10A levels or,
So they are not more difficult from it's not more difficult for them to achieve an anti-10A, compliance, I think, has improved now with the DOACs, or at least we think, because we can't measure them, right? But, it's sort of probably easier to take them, giving yourself shots twice daily. But, I don't see any difference between the patients with sickle cell disease and the general pediatric population in terms of our ability to achieve therapeutic levels of anticoagulation.
All right. Any other questions? All right. Well, excellent job to the both of you. Thank you guys very much for presenting today. And thank you everybody else for joining, and we will see you in a month or in 2 weeks. I'm not usually the moderator, so I don't know how frequently these are, but thank you all. I appreciate your time.
Thank you.